Oh, I see.
Good afternoon, everyone, and welcome to the Lunchtime Learning series. Today, Dr. Johns, an OHC medical oncologist and hematologist, will share his insight on lung cancer staging. Dr. Johns works out of the Eastgate office and has a special interest in breast cancer, colon cancer, lung cancer, and multiple myeloma, and is a member of the American Society of Clinical Oncology. He serves as the principal investigator for gastrointestinal, prostate, and genital-urinary clinical trials at OHC, and always encourages his patients to enroll in clinical trials to gain early access to the latest treatments. And just a reminder, this presentation will be recorded. Okay, Dr. Johns, take it away.
All right, guys. Thank you. Oops. This is let me just get that to happen. This is, they said, setting the stage, understanding lung cancer staging. Really, my goal was everything I know about lung cancer in 15 minutes. Okay. So when you're done, everything else is details. You just look it up. So, how big a deal is this? Pretty big deal. Lung cancer is the number two most common cancer in men and number two in women. So it's behind prostate in men and behind breast in women. About 100,000 new cases for men and women each year. But despite being number two, it's number one in terms of death. So down here you can see it's actually it takes out prostate and breast cancer by a good little margin. Um, that's the bad news. The good news is this: if you look at the incidence for men and women combined, it's been flat in recent decades. So we're not seeing more or less. We're seeing about the same amount of cases, but the mortality is actually dropping. And that's because we're doing better with our therapies and doing better with screening. So there's good news. What causes lung cancer? The purpose of this whole slide is just to say it's smoking. So it accounts for about 80 to 90% of cases. Everything else is kind of peanuts. So there's radon. It's a naturally occurring breakdown product of uranium that's found in soil. So it's radioactive. It's in your basement. There are venting systems to vent it out through your roof. There are radon detectors, all those things. Make sure your home has it. Asbestos. It's a naturally occurring silicate mineral. Silicate just means it's silicon, SiO4. So it's in a tetrahedral shape and has double bonds to all the oxygens. And I used to think that was important, but actually, kind of the nature of the beast is that asbestos, which is a great insulator, which is why people used it, forms these long fibers, and the fibers can't get cleared from your lungs. So it's what they term biopersistent. It gets stuck in your lungs and it forms a kind of an inflammatory process. You get oxidative damage in the lungs, and ultimately that's what leads to cancer. It's been banned, and that's probably on the decline. In terms of family history, there is such a thing, but really it's not per se traditionally thought of as a hereditary cancer. So it's not really like in terms of a single gene being altered, like a BRCA syndrome or Lynch, not really. But there are you can have polygenic sorts of predisposition where a patient inherits the right combination of genes. But right here, we say like the hazard ratio in one trial when patients had a high polygenic score was 1.16. That means they're 1.16 times more likely to develop lung cancer with a high risk set of genes. Um, but their hazard ratio was a mere 17.8 times more likely to get lung cancer if they're heavy smokers. So the whole name of the game, as you all know, is stop smoking. Here's staging. And guys, if you have questions, just you can always ask if you want to put yourself on. Otherwise, I'll just keep going. Um, Stage one lung cancer means that there is cancer in one spot in one lung and it hasn't gone anywhere else. Stage two typically means it's in that same spot, but it has spread to a lymph node right where the airway enters the lung called the hilum. Stage three typically means we have cancer in that spot, plus it has gone to a lymph node in the hilum where the airway is entering the lung, and it has now spread to these lymph nodes here, which is called the mediastinum. That's the space around the heart. And then stage four, we all know that means that it's spread to like the bone, the liver, the brain. Can a cancer be in one spot and be so big that it's stage two? Yes. So if it gets bigger than 4 centimeters, we call it stage 2A. Can it be so big and be in one spot that it's stage three? The answer is yes. If you get bigger than 7 centimeters, then we call it stage 3A. Can cancer get so advanced but not leave the chest that we then call it stage four? And the answer is yes. So if the cancer spreads from like this is the right lung, so everything, it's how you look at the patient, right's on the left and left's on the right. So if the cancer starts in the right lung, spreads over here to the left lung, that's stage 4A, even though it hasn't left the thorax. Also, if it enters the fluid around the lung or in around the heart, so a pleural effusion or pericardial effusion, those are all flavors of stage 4A lung cancer, even though it's still stuck in the chest. And that's all you really need to know about staging lung cancer. How do we classify these and why do we classify them? That's a good question. I mean, what we do is we look at them underneath a light microscope and we give them names, and we give them names because it correlates with cell of origin, clinical behavior, and molecular findings that are associated with a particular type of lung cancer. So we have small cells over here and we have non-small cells over here. The small cells are the fast growing ones, and the non-small cells are kind of slower moving than the small cells. Um, if we think of like lung adenocarcinomas, their cell of origin is this alveolar type 2 cell. And the thing to keep in mind is those are like the cuboidal cells that are present in the alveoli. So like the little air sacs all the way at the end of the airway where you get kind of exchange of oxygen and carbon dioxide. Those cuboidal cells that are the alveolar type 2, they make surfactant, which is what keeps your lungs from collapsing when you exhale. Um, but aside from interesting like trivia, the the adenos, those things are always usually peripheral in the lung because they're in the alveoli, which are like way out at the end of the airway, out peripherally. So it actually like makes sense, okay? And then like the molecular findings that you find, those are all the ones we know how to do something about. But if you have a squamous cell over here, those cell of origin are the basal epithelial cells, and those are in the more like central airway. So that's in the bronchi or in the bronchioles, and those tend to be more centrally located because of where the basal cells are located. And that type of lung cancer correlates with something called a 3q26 copy number increase. And all that sounds fancy, but the Q means the long arm of chromosome 3. And if you know that somebody has a squamous cell carcinoma, then you know that you're going to get copy number gain of 3q in pretty much most of those cells. That's important because it kind of you get what's called SOX2 overexpression. That's what is known as a transcription factor. Transcription factors are kind of the first step in turning on a gene, might just be the way to say it. And so we know that you're going to turn on a lot of genes because you're going to have SOX2 overexpressed. We just don't know specifically what to do about that yet, but you know what to say about the cell by knowing it's a squamous cell. And these small cells over here, their cell of origin is the pulmonary neuroendocrine cell. Those things are also found in kind of the more central airway, so back in the bronchi and in the bronchioles. And they're also located centrally, like within the chest when you find them typically. And that's the reason why. Those tend to be associated with loss of expression of RB1 and TP53, and those are tumor suppressors. Again, we know that that occurs, but we don't know quite what to do about that yet. And then this slide is my attempt to explain one of the major advancements in lung cancer. So when before I started, we'll go back in time. If you go back decades and somebody had stage 3 lung cancer, we would radiate those patients and you could cure some people. You'd cure about 5% of patients. And then at some point, we determined that if we added chemo to the radiation, the major step forward was that we could cure about 20% of the patients. So this down here is called a Kaplan-Meier survival curve. Everybody starts at 100%. This is percentage and this is time. And every time somebody either has their cancer grow or somebody passes away, they drop down. And this red curve here shows you what happens with old school chemo radiation. Okay. And these are stage 3 patients. So the cancer's in the lung, in the hilum, in the space around the heart. And, we've gone from an old school cure rate of about 5% with radiation to about 20% here with chemoradiation. And then if we add a year's worth of immunotherapy afterwards, in this case, durvalumab, we get close to 40% out there. And we're starting to cure. It's not half, but it's like, we're getting within, spitting distance of half just by adding a year's worth of immunotherapy. And the way that works, it's actually pretty interesting. We all have these things called T cells in our body, okay? And their job is to monitor kind of the cellular environment around them. And so it could be like the epithelium of the colon or the lung, or it could be a tumor cell. And what's happening is you've got this MHC right here, and every cell in the body is loading little snippets of protein that they're making onto the MHC. And what they're asking in really simple terms is this okay? Is this okay? Is this okay? And the T cell comes by, and if it doesn't like what it sees, it destroys the cell because if it doesn't like it, it means it's either infected by a virus and making viral proteins, or it's mutated and it's making, faulty proteins and it's going to turn into cancer. But you've got this signal over here, okay? Because it's a powerful thing to have a cell in your body that can destroy other cells. And this here, what this does is this tells the T cell, don't destroy me, I'm part of self. And so most of the available immunotherapies, like the durvalumab from the Pacific trial I'm showing you down here, what it's doing is it's actually targeting one or the other of these molecules to block that interaction so that you're getting rid of the signal that says, don't don't kill me, I'm part of self, and you're reinvigorating kind of the immune response that you had the brakes on through this interaction. Okay. And so that's really been one of the major advancements in non-small cell lung cancer. That, and then this right here. So this is kind of the mutational landscape of adenocarcinomas. And you can see that we have EGFRs and KRASs and ALKs and ROS and RET and HER2 and BRAF and all these things. And we're not going to talk about them all. The point is, we literally have IBs and ABs for all these things now. And we're getting to a place where it's starting to add up to a large portion of the lung cancers that we see, at least in the adenocarcinoma population. And is this important? And the answer is yeah. This this is actually hot off the presses from 2011. And nobody actually uses this drug erlotinib anymore, but it's the point that matters. And so this is looking at a patient population of stage 4 patients, so metastatic. These patients are terminal. Their cancer has spread to other parts of their body, and they all possess an activating EGFR mutation. And they took half the patients, and they said, we're going to give you chemo." Okay, so previously untreated, spread throughout the body. Half of them get chemo, and that's the blue line here, and half of them get a pill that targets EGFR to turn it off. And this is the chance of being alive without your cancer growing. And you can see, this isn't like a small difference. You're over doubling the amount of time that they're alive. And this erlotinib here, this is a first generation EGFR inhibitor. We're now given third generation EGFR inhibitors, which are easier to take in terms of side effects and are more effective. So if you put that on this curve, it would be like out here. We still don't cure these, but I have somebody who I met. He was 65 when I met him with stage 4. He's now just turned 70, and he's been on kind of one flavor of anti-EGFR directed therapy or another, still doing well. We have them. And so we're really changing. If we're not curing, we're beginning to palliate or super palliate, where these people are living years with their stage 4 lung cancer. And so it's really quite a paradigm shift, and we're starting to do that with large numbers of these patients. So it's the targeted therapy. And this came about by first having next generation sequencing so we know what to target, and then slowly developing, pills and IVs for all of these patients. It's really kind of incredible. Um, but the small cells, they've been totally left behind, guys, and they had been until recently. Um, this is from 2024. I believe this was the Adriatic trial. And I won't belabor this one. This is just looking at patients with limited stage small cell lung cancer. So that's stage 1, 2, or 3, basically small cell lung cancer that's in the chest that you can confine within a radiation port. And the traditional therapy was to give them chemotherapy and radiation therapy. And if you do, you get this kind of blue survival, which is actually better than chemo radiation alone with non-small cell. The problem being, for the most part, it spreads so fast you don't catch that many patients in limited stage. They're almost all metastatic. But if you did, we'd cure some people. If we give the same immunotherapy that we gave here to get this result, but we give it to small cell, and we give it for 2 years instead of 1 year, we get a curve that looks like this. And that's 48, 46. We're getting even closer to curing almost half the patients by giving 2 years of immunotherapy. And does this happen? I literally just gave somebody their last dose of durvalumab for limited stage small cell lung cancer today, and she's still progression free with essentially no evidence of disease. So it definitely does happen, and when we do catch these people in limited stage, we're really changing their outcomes. So it's miraculous. And then I wanted to talk about this. So what about the majority situation, what we call extensive stage small cell lung cancer, patients who have small cell lung cancer that has spread to other parts of their body? I mean, traditionally, what would happen is we give them chemotherapy, they all respond, and then they all progress rapidly, and then nothing else works, or it only works briefly, and then they live only a short period of time. And that's been effectively their problem for decades, really. And kind of in that space is kind of the miraculous discovery and development of something called BiTE therapy. That's bispecific T cell engagers. And what BiTEs are is they're actually fusion proteins. So this thing right here is a BiTE. And what's happening is you have two monoclonal antibodies fused together, okay? One recognizes CD3, so it binds to CD3. The other binds to something called DLL3, okay? So DLL3, that is present on the surface of about 85 to 95% of small cell lung cancers, but really isn't expressed on any other normal tissues in the adult human. So it's pretty specific to small cell. And CD3, that's a co-receptor on the T cell receptor. So this is supposed to be the T cell receptor right here. And off to the side, that little flange there, That's the CD3. They labeled it right there. Okay. And so it's kind of clever. I'm going to go back a couple if I, where are we? Oh, back a few, I guess. Um, Normally when the T cell works, what it's doing is it's recognizing the protein in the middle here and you're activating the receptor. But what's really, that's the way we draw it cartoonishly. But what's kind of really happening is there's co-receptors off to the side called CD3. And the way it works out is there isn't just one of these antigens and one of these MHCs. There's a bajillion of them all next to each other on the cell of interest and a bunch of T cell receptors. And if they're binding, they're all coming together, bringing those CD3s close to each other. That's called CD3 aggregation. And that's actually what gets the T cell receptor to activate and start stimulating the immune response. And so then what's happening here is by bringing a bunch of these, the tumor cell with a bunch of the DLL3 on its surface in close proximity to the T cell, and then bringing all these CD3s all to one side of the cell and bring them together, you're effectively activating the T cell, even though you're not really using the receptor per se, like it's not really actually recognizing the protein on the MHC molecule. So it's actually kind of clever on a couple fronts. It's also partially why it maybe doesn't, it works some fraction of the time, but you don't get the same quite robust immune response that you would with CAR T because it's kind of almost in a weird way bypassing the T cell receptor. Nonetheless, it stimulates the T cell to attack the tumor cell. Okay, and that's a good thing. So an immune response against the tumor cell is a good thing. The way it works is we give these drugs, and like the classic bite is tarlatamab for small cell lung cancer, and you give it during the day in the office. And then what happens is, sadly, they react at about midnight and they call us because that's what always happens for whatever reason. And they tend to get fever, low blood pressure, low blood oxygen, so hypotension, hypoxemia, and that's called cytokine release syndrome. And we give steroids and something that kind of turns off IL-6 called tocilizumab if we have to, and usually they get better right away. And the whole reason for doing all of this is this. We're still most are progressing, but you can see we've got a tail to this curve. About 20%, one in five, they just begin living with incurable small cell lung cancer. And does this happen? We have somebody in their practice who goes on golf outings, is just taking his tarlatamab once every 2 weeks, and he's about a year and a half in. Starting to get to the, if this were Keytruda, we have to start asking, when do we hold this stuff? We don't really hold tarlatamab yet. We don't have data for it. But I sent some email around, and we're all kind of getting that first group of patients approaching 2 years without disease progression. So it's really amazing. Um, we have trials. The trial's always your best option. And with that, I'll say questions. That
Feel
means I
free to
did a
come off
perfect job.
mute if you have any questions. So I have a question.
Uh-huh.
Because catching it so early has a better prognosis, should more people get like chest x-rays to
Yeah,
to
yeah, we
decide?
get good question. We actually do screening CTs is what we do for lung cancer. So when I started, there were no data for screening, okay? And then the only trial that was out was a trial looking at screening chest x-rays, and it was a negative trial. So oncologists were actually in the dual position of being successfully sued for not doing screening CTs, with no data to show that it worked, and insurers that wouldn't pay for it if you ordered it. Okay. But thankfully, there are no trial data that show that that's a good thing to do. So, if you have more than a 30-pack-year history, you can get what's called a low-dose screening CT, and it's once a year. And then they kind of categorize it with what they call like lung rads, kind of like BI-RADS for breast, where they kind of give a shortcut for what it means. And um, if you find something that's too concerning, then we get kind of a traditional CT and PET scan and go from there.
Gotcha. Now, another question. What
Uh-huh.
about people who grew up with, I mean, I grew up with two parents who smoked 2 packs of cigarettes a day. And we were often in the car with the windows like rolled up. Are you at a greater risk with that? Or,
Yeah, you
what kind
are
of
at a
effect does that have?
Yeah, so I mean that's also like a risk factor for developing lung cancer is secondhand like smoke.
Hmm.
I don't know, and like nobody crucify me. I don't know if that actually qualifies you for a screening CT, you know. You'd probably have to get creative and like invent a symptom to get it covered,
Hmm.
which I would not be above doing. But I don't know that in and of itself it confers enough risk, like similar to like the polygenic high polygenic risk score. You're increasing it, but I don't know that it's enough that it's really cost effective to actually recommend getting screening.
Gotcha. Good to know. Roseanne, did you have a question?
Yeah, I was in the same boat as you, Marianne. Both my parents are now passed away, but being in a car with windows rolled up and my entire family smokes, it's concerning about the secondhand smoke. But where do you start with this? Do I start with my primary care physician? Do I wait for symptoms?
No,
Like if
I'd
I
go
don't
to
know my family
primary.
history, I don't know where to start.
No, I mean they can primary and they can find an excuse to get your CT scan. That's what I would do.
Okay.
Good to know. Yeah, because often you don't hear much about that.
And obviously you want to catch it before you have symptoms because
Right.
when you
Yeah.
have symptoms, it's not going to be stage one.
Yeah. Any other questions? Well,
Yes, I
thank you.
have a question. I have a
Go ahead.
question. Sorry. Is there a higher incidence of shortness of breath with certain cell types and non-small cell lung cancer?
Yeah, I
Is
don't know that the answer particularly to that is really yes, but I think that like if you think about small cell, it grows faster, it's central, so there's more predisposition to like occluding an airway. And so then when you block off an airway, those patients tend to get short of breath. You know what I'm saying? And then
yes.
if you think of like a well-behaved adeno out in the periphery, you have longer to discover it. It has to be more advanced till it moves centrally. So it causing problems that are going to result in shortness of breath probably takes longer to occur.
Mm, okay.
Okay. But I don't know that it's really exactly about the cell type itself more than its
Okay.
clinical behavior.
Thank you.
No problem.
Well, thank you so much, Dr. Johns. This was really very interesting and very informative.
Yes,
All
thank
right,
you.
guys. Thank you
Yeah.
very much.
Okay, thanks. Thanks so much. I appreciate your time. And everyone have a great rest of your day.
Thank
Bye
you.
now.
too.